right, welcome everybody to the Conscious Mental Health Podcast. I am your host for today, Laurel. I'm a content developer with the Academy of Integrative Mental Health, and I'm joined here by my guest today, Laura Hensley. Laura, welcome. So happy to have you here.
Thank you so much. I'm excited to talk today about self-injury and trying to get more information out there.
Yeah, I really appreciate it because I think, like, as we were talking ahead of our recording today, this is just something that we don't have a whole lot of resources on in our organization, but like also I think it's really hard to find resources on, quality resources on generally.
Yeah.
For myself as a clinician, I've really noticed that. So I appreciate you being here, and I'm looking forward to hearing you share your expertise.
Yeah.
Yeah, can you start out just by telling us a little bit about yourself and your background and what led you to doing the work that you do?
Yeah. So I have been a licensed clinical counselor since 2007. And I feel like being a counselor was something I wanted to do for a long time, but getting into the specific areas that I work in, which really it's trauma and anxiety that are the big things that I do now. I feel like it was kind of an accident that it just kind of happens. You get into different things. I got out of grad school, I need a job. And the place I got a job was in foster care. And so being a therapist for foster kids, there's a lot of trauma. And it's chronic trauma. Even just being removed from the home is trauma on top of what got you to a place that you had to be removed from your parents. That it's just layers upon layers of trauma. And I think because I was there and I loved my clients and wanting to give them good care, you just learn more and more about the people that you're seeing. And I think as long as you don't hate it, you almost kind of develop your niche around where you happened to wind up. I know some people jump in knowing in grad school, I'm going to specialize in this. That was not me. I think in working with trauma, I started to see a huge connection between dysregulation and massive emotions. You see borderline personality, you see kids that are highly depressed, you see lots of PTSD, and all those things lend to the non-suicidal self-injury. And so, kind of by default and wanting to be competent, I think I wound up working and learning more about treatment of all those things. But yeah, I was in foster care for, I think, 6 years. And then I transitioned over to the practice that I'm in now, which is Viewpoint, back in 2012. And so the end of 2012, until I get six. And then I've been there ever since and gotten more and more niched and working almost exclusively with trauma and anxiety with people.
That's great. Thank you so much for sharing that path. That's, I think, very relatable for a lot of, it's relatable for me, certainly. You just get out into the world, and often where you land becomes your niche. And if we're lucky enough, it's something that we enjoy or at least find interesting and want to keep working with. So for our listeners, we're talking today about non-suicidal self-injury. Talk a little bit about how you differentiate, right? Non-suicidal self-injury from suicidal ideation, other self-injurious behaviors. What are some of the things you assess for right away? Tell us a little bit about that kind of overarching definition or set of definitions for you.
Yeah. So I think from the moment that I meet a client, I'm kind of setting them up to be able to have these conversations. One thing I think suicidal behavior, self-injury, all these things carry this liability that so many of us are afraid of that we almost don't allow the conversation to happen. So when I first meet with people and you have that like 2 minute spiel about like HIPAA and confidentiality and how all that works, I spend a lot of time talking about suicidal behavior and self-injury in that introduction. I make sure clients know that suicidal behavior, suicidal thinking, self-injury, these are all symptoms that I expect to see when they walk into my office. And that if they don't have them, that's great. But that these are the symptoms that might feel really icky or feel really scary, but they're part of our treatment and we need to be talking about them in order for them to get better. And then, of course, I talked about the range of if you cross a certain line, we need to talk about if a hospital is a safe place to be. But I really clarify with them, and I'm comfortable as a clinician saying, I'm not going to ask a client to go to the hospital unless I think they're going to die today. That if I
Yeah.
think we can keep them safe for even a few days, then we can buy some time. Let's reconnect 3 days from now, 4 days from now, and keep you at home functioning, more that CAMS model of suicide prevention. But by talking to them very openly at the beginning, the clients who aren't having any of those thoughts, who aren't having any suicidal thinking, who aren't having any self-injury, they're just kind of like, okay, thanks. And I've wasted 30 seconds of their life. But in that moment, I can kind of get a read for, is this person just looking at me like that has nothing to do with my experience? Or is this
Mm.
person looking at me and they're looking very guarded, like, oh no, I don't want to go there. I don't want to talk about those things, because that's something I can keep bringing up of, this is a safe place. And I can even start asking questions. What's happened in the past? Or what do you think might happen if you talk about self-injury, if you talk about suicidal thinking? Because for most Americans, not just most clinicians, they think of those things as a paired group. If I'm
Right.
self-injuring, I'm going to kill myself. And
Yeah.
even for clients who know that they're not connected, they assume that the rest of us are ignorant and think that they are. And they think, if I tell you this, you're going to think I'm going to kill myself. You're going to send me to the hospital. And their fear of me being afraid and covering myself will stop them from getting the treatment that they need. So, in that, a lot of people will be able to acknowledge when I give them that in the first 30 seconds. Later on, when I actually ask them about suicidal behavior, when I ask them about self-harming, or even homicidal behavior, that those thoughts and those urges that they might have, they're much more likely 40, 50 minutes later, when I finally get to that part of the assessment, to be able to acknowledge a little bit. And if they discount it, but I saw something early on, I might ask them differently. I might set them up to tell me the truth. Instead of saying, hey, have you ever had suicidal thoughts? I might say something like, tell me about how intense the suicidal thoughts you've had are. Tell me about any self-harming behaviors that you've had. And I'm really careful with clients, because stereotypically it's cutting. We think, oh, people are cutting. That's self-harming. Cutting is self-harming. Well, for some people, yes. But just as many, I find, are punching themselves, pulling their hair, biting themselves, burning themselves. That for somebody to just be like, oh, I'm so upset, and just pulling their hair out, that's self-injury. And so when I come to them and I say, instead of just asking the question if they looked guarded of like, tell me about your self-injury, I might say, so self-injury could be cutting, but it could also be hitting, or it could be hair pulling or biting. Tell me about how those behaviors fit into your life. I'm not saying, do you do it? I'm saying, tell me about those things. Worst case scenario, the client goes, well, I don't do that. And I was wrong in the way that I asked it, but I'm setting those people up who are nervous so that they can more easily admit, well, sometimes it's this, or sometimes I do that, or I used to do that. And if, of course, if I don't believe them, if I'm reading them as like, okay, it feels like something's guarded on day one, I'm probably not going to bring that up. I'm going to make a mental note. And as things progress, and I'm learning about the things they're struggling with, I'm going to go back and talk to them about, how are you handling when this really big thing happens? Are there suicidal thoughts? Are there self-injury behaviors? Is there any time that you want to hurt yourself when something like this happens? And just trying to keep that door open over and over and over again, just subtly or casually, so that they don't feel pressured, but so that they can acknowledge it and not be afraid of me.
Mm. Yeah. And that was one thing I was kind of wondering about too. Are there specific subtleties that you notice, right? So you mentioned noticing someone might be guarded. And I think so many of our listeners are mental health professionals, and we are pretty good, hopefully, at tuning into people, attuning to people, and noticing those micro expressions and just those different components of a client's energy that might indicate they're feeling guarded or fearful. But for you, are there specific things that you might listen for or watch for when you're having those conversations that would lead you to want to check in more frequently? with those clients?
Yeah. I think it is exactly what you're describing. It's these body language signals. So when I ask a question, are they immediately looking away from me? Do I notice like a tension kind of, and you can't see me, but like a tension in their body when I say something like that? Does their expression change in that moment? I think anytime that we see a shift in a physical expression from a client or from a facial expression from a client, just paying attention to what just happened immediately before this that might have caused that. Even small things like they went from sitting with their hands at their side to having crossed arms. What did I say right before that? Maybe my office is too cold. And so I don't want to assume, oh no, I brought up spiders and they cross their arms. Maybe it's just cold. But when they do that, I want to kind of, again, mental note, they cross their arms when I bring up spiders. That's probably something for us to go back to. If it's a client that I know well, we've seen each other more than for 30 minutes, I'm definitely going to probe and say, hey, you seemed uncomfortable when I brought that up. Tell me more about that. What are you noticing? What's happening internally? Bringing it, and we talked a little bit before about that somatic experience, bringing it back to their body. How did you feel when I mentioned spiders or the equivalent of that? But it is that nuanced stuff of what's their facial expression, what changed. And I think especially when we're newer clinicians, being able to trust myself when I'm looking at somebody, trusting that if something feels off, it's probably worth acknowledging, and maybe in a subtle way, maybe like, hey, I noticed that you crossed your arms. Are you okay? What changed? Instead of being like, you crossed your arms. How do you really feel about this? Trusting me to know, okay, I've spent, even the day I walked out of grad school, I have spent the last 2 years learning to be more empathetic, like honing that skill. I need to be able to trust that. I need to be able to trust that I can actually read people's bodies. I can read what energy is coming out of them or how their emotion is, and not just feeling like that imposter syndrome of I have no idea what I'm doing.
Yeah.
Because we do have empathy, and we've been building that and calling it when we see it.
Hmm. Of course. I think that's a good point of, you know, learning to trust ourselves as a clinician and um, how frequently that imposter syndrome really can arise. And we might not even realize that's what's happening. Right. And so reminding ourselves of that repeatedly in the same way that we check in with clients repeatedly, we have to check in with ourselves the whole time too.
Right.
Yeah.
Well, and I meant when I'm supervising people, I mention all the time, don't be afraid of mentioning your conceptualization, bringing up what you're reading in the room, because the absolute worst thing that can happen is you were wrong, which still leads the client to having further insight because now they've ruled out what you just gave them. And often they'll have a new insight because of what you said that helps them to like get a little bit deeper and a little bit farther into it.
Yeah. And I think that's a fear that has come up for me in the past. And I know I'm sure other clinicians have experienced that of if I say something that's off base, then suddenly I'm no longer a trustworthy guide or as knowledgeable as I want to present myself being. But I think that's a really good point. It's not our job to read our clients' minds and know perfectly every aspect of their experience, but it's our job to probe and ask. And I think that's a really smart way to think about it, is that even when we're wrong, we're still being helpful in some
Right.
capacity.
Well, and to me, it's also a cool thing to go back to when our clients are struggling and they feel like they have to be perfect, to be able to say, but last time we were together, I was completely off on something that we were talking about. And yet you continued to talk to me that day. Like me being perfect and knowing exactly what to say and exactly how to interact with you, normalizing that I don't have to have that. And I think it helps them too to see we're human and imperfect. My conceptualization, my reading of somebody's body language is not off base. I just might not understand them enough yet to know where it's coming from.
I'm curious from your perspective too. So we've been talking about some of those internal fears that might get in the way of asking the important questions or pointing out important things that we're noticing. But I also think, and have experienced for myself, especially as a newer clinician, there's fear around asking just because we're fearful of those topics. You know, you mentioned at the beginning of our conversation, there's liability involved, or we're told over and over how much liability could be involved. And so, my noticing is that there could be a tendency to not point it out because we don't trust ourselves, but not point it out because we have a fear that's preventing us from going. So, why do you think clinicians don't even want to work with non-suicidal self-injury, don't want to ask those questions? Is it just the liability piece, or do you think that there's more to it than that?
Oh, I think liability is at the heart of most people's reason. It is scary to think this person could die. I could be liable for their death. And we don't always pull apart. Well, just because they're self harming, one does not mean that they're suicidal. Self harming definitely can exacerbate suicidal thinking. And so there is connection to be always cautious about. But I do think this liability that we hold, I mean, I remember my ethics class, we said every day, anybody can sue anyone for anything, especially if they're wrong. Like that was like the mantra of the class. And while it's helpful because it teaches good documentation, that's what that's really about. At the end of the day, can I document that I have assessed for these things, that I have created a safety plan that both the client and I agree can keep them safe and keep them alive so that I don't get sued? Most of these cases don't even make it to court. And so it's the reality of, and most of us don't ever get sued. Even those of us who have experienced a client death, being sued is not part of that if we're providing quality care. And so I think people look at suicide, the self-harming, and they think, oh no, this is going to make suicidal behavior more likely. This is terrifying. But the risk involved in somebody who is truly just self-harming, and there's not an intent to die, is they are very unlikely to die from that self-harming behavior. And but it still somehow feels terrifying. The other piece that I think is there's a misconception that self-harming behavior is most tied to like borderline personality. I think maybe media has done it, maybe bad training has done it, but
Mm.
it is not exclusive to borderline personality disorder. And I think that there's a tendency for clinicians to be nervous about that diagnosis as well. It's a little bit more unpredictable. It takes more energy from us as clinicians to be able to hold those boundaries with people who are struggling so much with attachment. Sometimes that's a component. But really, if we ask clients in a real way about all the different kinds of self-harming, it is not most prevalent in borderline. It is most prevalent in people who struggle to regulate their emotions. It's the same way that if we have a developmentally very young child, they are more prone to tantrum because they cannot regulate. And self-harming is different than tantruming. These are not children we're talking about, but tantruming is a sign of, I am just so overwhelmed. I don't know what to do. And for somebody who walks up and punches themselves in the head or bites their hand or grabs something to scratch at their skin or to cut themselves open, it is really a sign of, I have so much emotion and I have no idea what to do with it. This is the only thing I know how to do.
And that, I guess, could be a fear in and of itself for some clinicians as well, right? Of like their emotion is going to be too much for me to hold,
Right.
you know?
Right. Well,
And
and as
so,
a clinician, what do I do for someone when their emotion is that big? How do I help someone learn to regulate their emotions differently? And there's behavioral components to treatment of this, but there's also this emotional component of, how do we help them develop more tolerance for being uncomfortable? I'm going to kind of expand a little bit on why I think this happens, because obviously borderline personality disorder, just in general, emotional
sure.
sensitivity and that diagnosis, and I say emotional sensitivity, but it really is pain. People
Mhm.
that struggle with it, if you can really get them to describe their experience of emotions, it is the same as somebody who is physically in pain, that they are actually hurting. And so they do get overwhelmed more easily and they react with bigger things because it hurts so very much. And so, yes, we see self-harming in borderline personality. We see it whenever anybody has too much emotion. But I think it's for a couple of different reasons. Sometimes it's too much emotion. I don't know what to do. For some people, it is what to do, that in some way by self-harming, it released some of that emotion. In the same way, I think most of us are guilty of, you get really overwhelmed and you go outside and you just scream for a second. At some point,
Yep.
most humans have done that.
Yep.
Uh, there is like this cathartic release of like, just go outside and, I can't do this.
Sure. Mhm.
For some people, self-harming has that same cathartic release, that it feels like something has come out, and it actually reduces their distress level in the moment to feel better. For some people, self-harming is about dissociation. And that's where I see it more with trauma responses, is that people who are highly dissociative need to feel something. And so it's almost like that's shocking my system. Where someone might splash water on their face, someone whose tendency is to dissociate more might do something like scratching or biting to bring themselves back into the moment.
Yeah.
And so I think it's trying to understand, where does this behavior come from? Is it purely symptomatic of borderline? Is it that I have so much emotion, I don't know what to do? Is it that I'm so numb, I have to come back into my body and into this moment to be able to feel better? There's a couple other smaller reasons that people could be self-harming, but those are probably the most common places that you're going to see it. And helping clients understand why it's happening is one of our first jobs. Why are you self-harming? And as a clinician, being comfortable going to that deep, dark place because something terrible is happening, that ripping my skin open feels like the best option.
Right. I think that's well said. How are there other ways that we can improve professionals' comfort levels and clinical competence in working with these things, beyond just saying, okay, you need to be comfortable going to that deep, dark place? I think that's valid, right? And
But how?
what how do we do that? What do we do? Because I think that something that I've encountered in lots of different areas of my clinical life, I think, okay, I can conceptualize this. I know what to do, but what are the concrete takeaway? Like, how are those steps put out there in front of me to get to where I need to go?
I think obviously there's training that's necessary, and
Sure.
looking to see like what I actually need interventions to use with clients. But short of that, I mean, that's kind of an easy answer. Go take a class, learn how to do this. I think the most powerful thing for most of us is another professional who is comfortable. And whether
Mm,
that be a peer support group, whether that be paid supervision, um, I think I need someone else who can tell me, I can do this. And that sounds weird to say. Like, sometimes we don't need someone to tell us what to do. We need someone to say, you can do this. You handle hard things. You can handle your client doing this. You're doing it well. And I think the advantage of being in a group practice or an agency is you can bump into somebody in the hallway for 30 seconds and go, I just need to run this by somebody because this is a lot. And getting that feedback of, you're handling exactly the way that I would handle it. And being able to feel a little bit of validation. And I didn't just break someone, because there is that underlying feeling for us as clinicians. What did I do? Am I hurting people? Or am I really helping?
right. Yeah, I think that all the time, just like my number one is do no harm,
Yeah.
right? And so I think that internal critic, just like with any other human, can easily come up after, especially if we've had a difficult session or we're really struggling to feel competent. That thought can come into our mind of, oh, you were supposed to do no harm and maybe you did harm,
Right.
right? And so that is so valuable. I agree, to have those other professionals and colleagues and support people in your life who can understand what that really means and what that really feels like, and give you validation around that.
Yeah. I love what you just said, this mantra of do no harm. And I think there's an assumption that it's the doing that causes harm. But if right now I could see behind you that your wall is on fire, and I choose to do nothing, I'm doing harm. And
Mhm.
that's where I think that sometimes we can unintentionally cause harm by not going to the scary thing, by not addressing the scary thing. I've seen numerous clients show up that have adjustment disorder to come see me. And I talk to them for a session, maybe two. And it's like, you tried to kill yourself 3 times. You've been self harming since you were 12. And it's the wall has been on fire this whole time. And I think every time that as therapists, we're supposed to be this safe place, we're supposed to understand clinical symptoms. And every time we don't allow space for those deep, dark, scary things, what we're doing is reinforcing that our clients should feel ashamed. And shame is a huge part of why
Mhm.
mental health gets out of control, why symptoms can't be managed well. And so by allowing space, by addressing the fire behind you, then I am actually helping, even if I'm not 100% sure yet. And I say, I'm going to get some consultation on this. I'm going to do some training on this, and we're going to work on this next time we get together. But giving that confidence of, I know where to get these answers. I know how we're going to move forward. Just let me get a better plan together before we meet next time. But helping them to know, like, I know, I see that the fire's there, and I'm not going to let you keep walking around with it.
Mhm. That's such a great metaphor because I think that really brings it home of so many times if folks have been in treatment of any kind, some kind of fire has been ignored at
Yeah.
some point. And so just pointing it out can be a complete 180 difference from what they've experienced so far. And I also love what you said about owning, like, hey, I need to get some consultation on this, or I need to do some more research into it, because I think a lot of times we're also afraid to not have an immediate answer.
Mhm.
Um, and so just owning that, but also creating a sense of confidence of I'm going to do this work. And I recognize that there are answers that I just don't have in my mind yet at this very moment. That's a great bridge that
Right.
still helps to open up space for conversation and for building safety and for building relationship. So I think that's so
Well, and
smart.
even when I don't know what to do, we all know how to investigate. We all know how
Right.
to help the client develop insight. We all know how to understand what's going on, and to really look at symptoms. And so it's lean into what I do know how to do and then acknowledge I'm going to set something up. I think so often there's this feeling of, and I remember the first probably 10 years that I was practicing, this feeling of like, I'm supposed to know it. I'm supposed to know what to do. And this pressure to
Mhm.
like go out and Google things or find the training that I'm supposed to be doing. And I always did consultation, but I've gotten much more comfortable in the fact that, of course, I'm doing consultation. Why would I know how to treat all of these disorders? Why would I be the expert on literally the entire DSM? Like, that doesn't make sense. I'm going to be niched in my couple of things, and then I'm going to get help. And so with intention. I have another EMDR colleague that we consult on complicated cases regularly. We kind of trade services that rather than pay each other, we consult on each other's cases. Within the last year, I consulted with a DID specialist because I recognize, while I understand dissociation, this level of dissociation when someone isn't even aware that they have DID, I'm not prepared for. This many
Mm.
years into my career, I am going to pay someone $200 to talk me through my treatment plan, things that I should have learned in grad school. No, we don't learn that in grad school. And I think if we can get over that idea, that's really helpful. And so I share my silly example of like, I really am doing these things, not because that's what everyone needs to get consultation in, but because it should be normal that even though I'm an expert in these few things, I'm going to need help. I'm going to need colleagues, supervision, one-time consultations to be able to handle whatever happens to walk in my door.
Mm. Yeah, that's so true. As you're talking, I have lots of ideas boiling around in my head, but I'm curious your thoughts on where that comes from for clinicians, because I know you mentioned I didn't learn that in grad school. There was so much I did not learn in grad school. Let's just be honest.
Right.
Love the program, bless. But there's so much learning that I have done since I've left in the 10 plus years since I've left grad school, right? That I didn't get there at all. It's like I'm a completely different professional now, which is great. That's what we're supposed to do. We're supposed to grow and continue learning. But why do you think in our field especially, we all carry around this belief that we should leave grad school knowing every answer, every diagnosis in the DSM and exactly what to do with it perfectly? I feel like that's something that is maybe not exclusive to our profession, but certainly to an extent is very specific to our profession.
And I don't have like the answer. My assumption is because our clients look at us like we do.
Mhm.
My clients
Yeah.
come to me and they want me to be able to tell them that I can help them. And I want to be able to say that. And because that dynamic of caregiver is one where we're kind of the nurturer, we're the like professional person in the room. I think sometimes we take this burden on of like, okay, they're looking to me for this, so I should have this. I should know exactly how to do it, and I should be able to answer all of these questions, and I should know what to do. And we just can't. And so I don't know if it's, I think culturally, just as a whole, America tends to be we're very independent. We're very like, I can handle things. We pull ourselves up. We can do this stuff. And instead of recognizing that the collective group is much, much stronger and more effective, the treatment team is more effective than the individual therapist. If I can
Mm,
connect with other people and get more insight and more perspective, my conceptualization can actually grow and be better for my client.
right. Yeah, I think all of that is right on. And then I think that individualism really plays a part in it. I'm also curious if perhaps, although I feel very grateful in some ways for the sort of shift over the past few years of therapy becoming very popular. While it has become so popular, like even on social media and things, that now it's become sort of the singular answer to every problem is to go to therapy. And so there feels like a lot of pressure on the therapist to say, oh, well,
Here's my
everybody's coming to
thought.
me now.
Yeah. Yeah. Let me share
Yeah.
my wisdom of all these things. So preventatively, I think I kind of address this with some of my clients in a way that maybe can help somebody else. That again, in that initial session, I put ownership on them. And I think I kind of took this out of supervision that I had later in my career when I was starting EMDR, which has been only the past decade or so. I had a supervisor who was really helpful and kind of calling me out on trying to fix things for my clients instead of making them
Mm,
show up ready to do the work. And I
mhm.
think his words were something like, why are you working harder than they are? That you're with them for an hour. They've got 167 more hours before they see you again. Your 1 hour isn't going to change that. And kind of recognizing the significance of him letting me off the hook, and seeing him. I mean, he's on the verge of retirement. It was fabulous and well known in our area. So I was like, okay, Don's not crazy. Like, I'm not supposed to be doing this. He gave me permission. And so now when I meet with clients, I really do give them ownership of our relationship. And I tell them a couple of specific things. One, especially my younger clients, I tell them that they hired me. And so when I'm not
Mm,
doing something the way that they want it, they need to talk to me about it. And maybe I can give them rationale and I can explain why I'm going about it this way. Or maybe I heard them wrong. And I kind of use it with the comparison of painting. Like, you told me to paint the room blue and I'm painting it sky blue, and really you wanted royal blue. You need to help me to understand what you're looking for. But also going to them and saying, when we get together, I cannot do this alone. I will bring in all the clinical expertise that I have. I will collaborate with other people to bring you even more clinical expertise so that you get the best resources that you can have. But you will always be the expert on you. And so without that expertise and without you directing what we're doing, none of this could ever work. And so kind of helping them to feel some ownership and responsibility, one, helps them be motivated clients. And two, helps me to be like, I'm not supposed to figure this out. I'm supposed to provide what I have. And only in that collaboration can I do anything.
Mhm. Yeah, that makes so much sense. And circling kind of back around to this conversation that we've been having around self injury, I think helping clients to feel empowered to do something differently
Right.
can come from that, right?
Well, and I think one of the things, and this is a terrifying thing for me to say, but when I'm talking with my clients and I share with them, you've hired me, this is about you being the expert of you. I let them know I am biased. I do want you to stop self-harming because I don't like that you're hurting yourself because I like you. I tend to validate, like, you're a likable person. I don't want you to be hurt by anybody. But I
Right.
also give them permission to not change. If you continue to self-harm, I'm not going to force you to stop that. I'll stop you from doing it in front of me, but I'm not going to stop you from self-harming. My job is to help you figure out if self-harming is actually helping you or if it's a behavior that you want to replace with something else. And that permission helps a lot of clients have real conversation with me because they're not afraid to come in and be like, yeah, I self-harmed 10 times this week. They're like,
Right.
okay, let's talk about it. What happened?
Mhm.
Did it work? That's a question I ask a lot. Was it helpful? Did it meet your need? Is there anything else that could meet your need? Helping them to really investigate, where does this behavior come from?
Right. And I do appreciate that reframe very much because I don't think that that's how a lot of us take what we're taught in school. Like a lot of us take the message that we should be immediately stopping the self harm
Right,
immediately,
right.
right?
What's really terrifying with my young adults, my middle-aged adults, or even old-aged adults, um, that conversation is exactly what I said. What's really scary is when it's my adolescents, because
Mhm.
that conversation has to happen with mom and saying, we're working and helping them to understand motivational interviewing. We're working to get them through these stages of change. You brought your child here against their will. They do not see this as a problem. My job is to help them to move from that pre-contemplation to contemplative stage of, maybe this is a problem, and helping mom and dad realize we might see some reductions in self-harm, but there might not be any change for a couple of months. And if I can give that to parents up front, if I can help them to understand a treatment plan, help them to understand we're trying to get your kid to want to change, they're not happy that their child's not going to stop self-harming on day one. Magically, I fixed it and everything's great. But they can see the big picture of, we're trying to resolve these underlying things to empower your
Right.
child to choose differently.
Right. Yeah. I can imagine those are very challenging conversations, but framing it within that stages of change model could certainly provide more hope
Right.
and a path forward, which is, I think, what most people want ultimately. They just want to know, okay, if it's not happening today, will it happen at all? Or is there possibility that this can change at all?
Right.
And we know that there is, and we know that mantra, trust the process. But as clinicians, when we find it hard to even trust the process sometimes, how do we help bring those clients or those parents of clients into that process and being present to sit with it without giving up? And so I think that that could be very powerful to have that
Right.
conversation as well.
Absolutely. And I think finding a way that each individual clinician is comfortable teaching spouses, parents, anybody, any support system person who's involved in treatment, what that motivational interviewing stages of change is probably one of the most important things we can do, because otherwise therapy is seen as a magic wand.
Right.
Like, I'm going to go here, you're going to make me stop wanting to hurt myself. I'm going to go here, you're going to make me stop feeling anxious, or whatever they're coming in, it's going to stop. You're going to stop it. And helping people to realize, hey, this is what it really looks like. And then, so 6 months later, when a parent's like, we're still self-harming sometimes, that I can go back and say, well, here's where I see them on that stages of change model that we worked on. And it's not, once I get done with box one, I get a check mark and I never go back. It's, we're going to ebb and flow moment to moment, depending on what's happening and how we're doing. But I think that, to me, is one of the first important treatment things, is helping people understand how change happens, both our clients and their support, so that there isn't an expectation. and therefore a feeling of failure when it doesn't happen. Because again, if I feel like I'm failing, then who cares? I'm done. I'm just going to keep self-harming. I'm going to keep doing this. My mom's mad at me, so whatever.
Right. Right. So that's kind of the first step, it sounds like, in the way that you approach treatment, or at least one of the first steps. Can you tell us and our listeners a little bit about what that treatment process looks like generally and how you
Right.
work with that?
Right. So once they understand the stages of change, obviously somebody who's not in the preparation stage, we're information gathering. I'm trying to talk them into not self-harming, a lot of like change talk. How do I get this going? But once they're even in that stage 2, definitely once they're in stage 3, it's collecting data. Once they sort of want to change it, it's going, okay, well, this is something you told me you're not thrilled about doing. Let's understand it more. The way that I work on any behavioral change looks very similar to like substance abuse changes. Let's look at it as a relapse. Let's look at it as a behavioral thing. What's the details, the who, what, when, where, and why? And I ask people specifics, like where exactly were you? Well, you were at home, but what room were you in? Were like you were in the bathroom? Was it your bathroom, somebody else's bathroom? Were you in your bedroom? Were you in bed? Were you on the floor? Helping them to really understand like where are their high risk areas, because as we start collecting data, they start seeing patterns before I do, because they're collecting it throughout the week for me. They're noticing, even if they're not writing it down, because we all know clients very rarely do homework. They're at least noticing a mental note, because they're like, she's going to ask me, I have to remember this. And they'll
Mm-hmm.
kind of start to note, like, I'm always self-harming in my bed, or I'm always
Mm-hmm.
self-harming in my car. But I'm also asking them like the when, what day of the week is there vulnerability there? Is there time of day that there's vulnerability in? Are people around? Is no one around? Are the people in the house just not in the room? Um, I asked them about like emotional triggers. Like, is there anything that happened situationally, emotionally, that could have triggered this event? Was this an untriggered event? You just had this impulse to do it. What were the barriers in between having that first urge to self-harm and actually self-harming? What did you have to do? If you already threw your razors away, did you run to the store, go find your item, have to go get cash because you didn't have it? Like, how many minutes were between that first urge and actually doing it? Because that's one of the things, if we start tracking, it can become a motivator to get them to put roadblocks in the way.
Mm-hmm.
If you want to stop
Mm-hmm.
self-harming, well, just don't let yourself have that self-harm item around. If I'm hitting myself, maybe I'm doing something like wearing mittens so that I have to take the mittens off before I can hit myself or bite myself. Even those like just 2 or 3 second delays, there has to be intention besides just like the impulse to hit myself or cut myself or whatever it might be. So I'm collecting all this data. What's happening? What exactly is causing and building up to this? What emotions were you having? I think I talked about triggers, but just in general, how were you feeling before you self-harm, to help me understand, is this a numb person who's trying to feel something? Are they overly emotional with like sorrow or anger? Like, what tends to be their trigger emotion? I'm again increasing my conceptualization of them as a client, but also how self-harm fits into their symptoms. So once we start to find those triggering the patterns, those pieces of it, the time and place and whatnot, then we start to talk about how do we put barriers there. If I know that Monday is always a high risk day, what can I do Sunday night and Monday morning to reduce my risk? And we start experimenting. What might make it easier? What are you doing on Tuesday that you're not doing on Monday? How do we make it so that Monday feels more like Tuesday when you can handle it differently? It really is, there's no clear answer. It really is with each client finding their individual vulnerabilities, building up resilience around those vulnerabilities. When I get angry on a Tuesday, I do this. How come we're not doing it on Monday? What's stopping us from doing it on Monday? Helping them to recognize there's something wrong. If you can do it sometimes and not other times, what's happening in those times when you are self-harming still instead of resisting that urge?
Yeah. And it sounds like that could be an incredibly helpful process, but for some folks, it would take a while.
Yeah.
Right. And so is that part of that stages of change where you keep revisiting, hey, it's okay if this is taking some time, It's okay if we haven't figured out every piece of this puzzle. We're going to keep exploring and keeping that confidence up.
Oh, absolutely. And I think the finding the patterns can actually happen really quickly if the person is
Sure.
regularly self-harming, because you're going to ask enough questions to be able to find some thread of something that you can say, well, this is always the same. You're always angry when you're self-harming, or you're always really sad or crying when you're self-harming. The experimenting part takes a lot longer. And for clients who aren't self-harming often, finding the pattern takes a lot longer. But we also can make assumptions earlier, even with just one or two pieces of data, to be able to say, well, both of these times you were really sad. So when you think back, is sadness one of the biggest triggers? And being able to make some assumptions, even though we've only got two pieces of data, which is not really a ton, is normalizing. Like, we're going to be guessing, we're going to be just working on this. But for them, I mean, for me as a clinician, if I've worked with them for 3 weeks, this is a new problem for me. But for clients, by the time they've gotten to me, this is not a new problem. They have been self-harming for months, if not years. Yes, I want to see it change, but helping them to recognize that, like, hey, it took us a long time for this problem to get this bad. Let's figure out, like, it's going to take us time. Let's figure out how we can actually make this problem go away for good, or 90% of the time be gone. And just normalizing for them, it's going to take us a while to figure this out. The
Hmm.
other piece, when we collect all that data, is looking for the need. And
Hmm.
so sometimes, like I said, it's that I'm numb. So what else can help you to ground yourself? How can I help you dissociate less so that you don't get so far away, that you really are grounded in the moment and not needing to self-harm to come back because you haven't gone off and been lost for the last hour? A lot of times the needs are very emotionally driven. And so it's just, like I said, it's experimenting, not just how do I prevent it, what barriers can I put in place, but how can I meet this need in a new way? And so the experiments are a lot of, like, in session, I'm brainstorming with clients, we're going to go try things. But the bulk of session time really is understanding these deeper levels of, when you're self-harming, what are you hoping to accomplish? What do you need in that moment? What did you need rescued from something? Did you need something resolved? What happened? And how do we meet that need? Let's not just pretend that the need's not real, because that's the temporary fix. That's like the equivalent of the yo-yo diet. I can cut out sugar for 3 weeks, yes. And then I'm putting it right back in. And how do we help our clients recognize the need for sugar is real? We can't just cut that out. Well, it's not necessarily a real need, but for me it is.
I think that makes so much sense. I'm curious, as you're talking, you had mentioned putting barriers in place, and that certainly does sound like models of like relapse prevention and things that probably many of our listeners are familiar with. But I think what I've encountered is there are kind of differing opinions across clinicians around like safety planning. And you had mentioned, maybe you don't have your razors available, or, something along those lines. And is that always a part of that in putting those barriers in? Or do you ever have you ever encountered situations where we don't safety plan by removing all of the self-harming instruments? Like, there's other ways to approach this. I could see people having various thoughts on that.
Right. Well, I think when you talk, so with cutting, it's where we need an instrument. I mean, it's
Sure.
possible to cut with my fingernails. It's not as common. And to
Right.
say I'm going to remove every item that I can scratch or cut myself with means no knives, no paper clips, no butter knives, no
Right.
tacks, no nail clippers. Like, short of living in a padded room, if I want to self-harm, I'm going to break something and have something to self-harm with. So to me, it's not, how do I remove every sharp object from my client? They can't be around this thing. That's the panicking. I'm going to fix this. So what I'm saying
Right.
to my client is, and numerous people, if you ask them what they self-harm with, they have 2 or 3 items that they use, and that's it. Like, they know
Mhm.
what they're using to self-harm. Some people, it is this impulsive, whatever I can grab, whatever I can get my hands on. And that's just too much. But for most of our clients, they have the knife in the kitchen. And that's the knife that they use to self-harm. And if they're adults, they usually don't use it for anything else because that's gross. Like, that's the thought process that my clients will give me. Like, I don't cut chicken with that. I use that for me. Like,
Yeah.
no one's
Yeah.
salmonella. And like,
Fair.
really is this logical thinking. I have clients that go to specific stores to buy specific razors that they keep, that they only use for self-harming. And I think a great deal of clients, when we really can talk in depth with them, a great deal of clients have these ritualistic pieces, very similar to how drug addicts have them, that they have, they could smoke any way that they wanted, but they have their papers that they like or their bong that they like. And yeah, I could use something else, but I really, really like to have this. And it's kind of recognizing that our self-harming clients really do have preferences fairly often. Even
Mm.
when it's high impulse, they prefer to bite themselves or they prefer to grab their razor and cut themselves. So when I'm working with a client, I don't say, you have to put these barriers in your way. My job is to say, I noticed that you're always using the yellow kitchen knife. Is there anything
Mm.
that could make the yellow kitchen knife less triggering for you? Because when you open that drawer and you see it, you're triggered. Is there anywhere that we could keep it that wouldn't be as triggering? Or what can we do so that when you see it, it doesn't feel as triggering? Can we start using it for cake? Maybe then it can
Mm.
become the cake knife and have another association. So at no point am I telling my clients, you have to. I'm very often collaborating with them and just saying, I'm noticing this. What can you do? And it's again, put
Mm.
that ownership on them. Do you need a barrier between you and this thing? My clients are really in that stage 2 and they're kind of waffling between 1 and 2, I will make connections with them about how it is an addiction when they've been cutting for so long and they do have these rituals attached to it. And we'll kind of, depending on my client, depending on how well they know me, we'll make connections with addiction and say, this is your heroin. And yes, it's not a
Yeah.
narcotic, you're not breaking the law, but you need to treat your razors the same way that you would treat your needles. Do you need your needles in the car? Should you be carrying heroin in the car and think that you're going to stay sober? If you don't want to stay sober, you do need it. But you're telling me you want to stay sober and you don't understand why you're not. What can you do to get that away from you? And sometimes that connection, again, with the right client who's not going to be offended that I've just called their self-harming heroin, it really does like light up for them of, oh my gosh, that would be stupid. Why would I keep heroin in my car? Like they start to kind of get it, why having barriers in place would be helpful. But I don't tell my clients what to put in place. I don't say you have to remove X, Y, and Z. I will make encouraging statements of saying having those around is going to be really dangerous, but it's not mine to take away. And the same way when they come back and cut, I'll say, if you come in and you cut, I'm not mad at you. I understand that that's going to happen sometimes. I understand that 10 years from now, you might have a relapse where you self-harm, and it's not because you failed. It's because something unpredictable happened that we hadn't dealt with yet. And we need to help you build up some resilience around that too. And so helping our clients not feel ashamed or embarrassed or like failures is one of the biggest things we can do. And then getting them on board with what barriers do they think they need and helping them find that.
Yeah. I really appreciate that idea of all of this being a very collaborative process, right?
Yes. Yeah.
Because obviously, so much of the way that we're taught about how therapy works is c- collaborative, or we hope that it's collaborative, right? We're creating collaborative treatment goals and what's the client wanting to get out of it. But I think when it comes to safety planning for many of us, a lot of our training, especially if we've been inpatient, has been much more directive and
Yes.
clinician guided,
It's
right?
CYA. Cover myself.
Yep. Yep.
I told you to
Absolutely.
put that knife away and you didn't. And that's why this happened. And that's parental. I love my
Sure.
parents. I don't want them to parent me. And even as a teenager or an adolescent or a child, I didn't want my parents to parent me. And so coming into a therapist's office to have another person parent me is more likely to me resisting that versus me empowering them and saying, this is what I'm noticing. What do you want to do with that? And being their, like you said, like their collaborator, their cheerleader of, I know this is hard. I know that what I'm talking about might not be something we can do right now, but I also know that we can. at some point. I know that you can get there because I see you do hard things. Helping to encourage them to have them make those decisions, I think is the only way. It's the only way that I've ever seen success.
The most challenging part of this work for you? And then, but what's also the most rewarding part of this work for you?
Yeah. So challenging is not being in control. I'm a little type A, and watching people do things that I know are imploding their lives is very hard. But it's with intention that I have to go into those, because you kind of know the clients that are going to come in and have not made progress, or they're going to be doing things that are backfiring on them. That to me is the hardest, not trying to fix it, because I genuinely adore my clients. I think that they are just the most amazing, wonderful people, and watching them be hurt by anyone, even themselves, is hard. But the reward is I get to work with these amazing, wonderful people. And I think because we're so collaborative, they see me as valuable as well. And there's this reinforcement from them of appreciation and of enjoying the work. I mean, not always the moments, but like overall being able to enjoy what they're getting out of it and enjoy what they're seeing change. That it's just, it is incredible to watch what people are capable of when they're given a place to really accept themselves so that they can.
Mm. Oh my gosh, that's so true. I think that's, for me, that's definitely the most rewarding part as well. Just like getting to see people be empowered from inside of themselves
Yeah.
with the right scaffolding and framework. So that makes so much sense. But also the control piece is very hard because I get it.
Very hard.
We all want to be rescuers, as
Yes.
we've been talking about.
Yeah.
And so it's hard to put aside that rescuing part of ourselves at times.
Right. And I think it's an awareness on our own part of when my rescuer is activated, this is not healthy.
Right.
I'm not doing therapy anymore. And
Right.
being able to be aware of my own vulnerability and tendency to want to rescue people, and instead just say they actually are very, very capable. I don't need to make them a victim.
Absolutely. Yeah. So we always kind of ask this as a wrap up question as we start to finish out our conversation and land the plane today. Is there any sort of a practice or a technique or an experience that you and I can talk about or walk through that would really give our listeners a specific taste of the work that you do?
So I had an idea when we started that actually
Mhm.
changed as we were talking, because I was like, oh, this would be a good thing
Great.
to talk about. So we're going to change.
That's great. I'm up for it.
Because I think dissociation is so tied to the people that feel numb. I think helping clients understand what dissociation is, helping them to be able to conceptualize it as well as be able to address it, so that they're numb less often. So like this would be for that client, and they're recognizing I need to use self-harm to come back when I'm really, really gone. How do we
Mm,
meet this need? So this technique and this conversation will be part of it. I
right.
think in metaphors, I talk in metaphors. People that don't like that hate me as a therapist, but I use metaphors. My metaphor for dissociation is a hot air balloon. And so it's thinking about, and we probably have all seen them at like state fairs and national monuments. You got this hot air balloon tethered to the ground. It floats away, it comes back down. It floats away, it comes back down. And that is dissociation. Because as I float away, I can make out less of what was on the ground. I can hear less of what was on the ground. And if we think about that being our mental state, and I'm the person beside me on the ground, I can't feel the person on the ground anymore either. And so helping them to kind of normalize, this is like your mental state floating away like the hot air balloon, and we're going to bring you back down. One, I think that is an important, just that little conversation with clients is an important conversation, because what they're doing when they cut themselves or punch themselves is they're like ripping the balloon back to the ground all of a sudden.
Mm,
And that's great. But if we're talking about 500 feet of rope, it took something that drastic to bring you back down to earth. So the problem isn't what else can bring me down 500 feet all of a sudden. Well, probably nothing. There's probably nothing I can tell you that's going to have that level of impact besides to just keep doing that. And so teaching clients and getting them to kind of buy into the idea of your balloon can't float so far. I need you to be more often grounding yourself in the moment and bringing yourself back down, and kind of thinking about those typical anchoring and grounding techniques as like a hand over hand approach to that rope. We're bringing it
Mhm.
down just a little bit at a time. It's not going to come back 500 feet. It's going to come back 30. And if you're 500 feet away, you're going to have to do this a lot of times. So a technique that most of us have heard, this is probably not going to be earth shattering to anybody. It's that anchoring with your five senses. There's a few pieces when I'm talking to my clients that are really important. Sometimes they are at 500 feet and they do not feel their body at all. And so when I ask them, what do you physically feel? What's touching you right now? And they're just like, they deer in headlight, like I'm supposed to say my leg. Okay, read that. They're not sure.
Yeah.
And as soon as they look off, I say, if you can't feel anything, I want you to look and notice what you should be feeling. And I'll say something like, notice your feet on the floor. Are they pressing evenly on the floor, or is it more pressed on your toes or on your heels? And getting them to just notice that. Or I'll say, I want you to look at your legs and notice that one is on top of the other. Can you feel the weight of that leg? And sometimes the combination of I see it and I feel it, that kind of helps them to come back into their body a little bit. When I'm doing visual, the big thing that I emphasize to clients is don't just tell me what's in the room. When you're at home, you can tell me and you can right now, you can tell me exactly what's in your bedroom, exactly what's
Yeah.
there. You've been in that room how many hundreds of thousands of times, you know where every single thing is. And so helping clients understand, going through that process, just naming off the things, that could be your third eye. You could be visualizing in your head, which keeps you at that hot air high level. We don't want to stay high level. So when I'm asking you to look around the room, one of two things. I ask people to look for things that are out of place. So like in my office, they kind of look at me like, what do you mean? I'm like, well, I've got the paper sitting right here. I don't always have these papers sitting here. This is out of place for my office. Whereas like the artwork, it doesn't typically change. So they'll notice a few things. I tell them to look for specific colors or textures. So like if you're looking around your own bedroom, find something pink and go over and grab it. Like, don't just picture your bedroom like, oh, I have a pink book sitting on the table. No, go touch the pink book, and so that your eyes are actually involved in finding that pink thing. In my office, one of the fun things, because EMDR is very dissociative, I have them go on scavenger hunts. Like the women that I have that bring in their big bags, I'm like, get in your bag and find me something scratchy. Get in your bag and find me something purple. Things that are kind of different than normal. But again, this is just this hand over hand bringing me down to earth.
Mhm.
What I want to do is, after I teach a client how to do that with physical, visual, auditory, taste, and smell, then I'm going to give them the assignment of, I want you to keep your balloon closer to the ground all the time, because when your balloon gets above 200 feet, you are going to dissociate. And
Mm.
so, like, to the point that you're going to need something drastic to get you back. So I'm going to
Yeah.
ask them to set an alarm on their phone or on their watch, and to anchor themselves to the ground, to bring their balloon back down every 30 minutes for 2 or 3 weeks. Every 30 minutes, anchor yourself. It doesn't matter if you're not 200 feet away. I want you to be as close to on the ground as you can be, because then we're able to actually prevent them from dissociating that much.
Right. Yeah. That makes so much sense. I'm really glad that you shared that metaphor. I love a metaphor also.
Yeah.
So that helps me. So I really like that idea of going ahead and pulling the balloon back down, not waiting for it to get 500 feet in the air, because I do think so much of the way that maybe unintentionally even we frame grounding strategies is to use as like not preventative,
Yes.
but to fix a situation.
Right. Right. We're reacting.
Yeah, it's very reactive. And I get it. I get why. We're so busy. We've been doing things one way for our whole life, potentially. And
Yeah.
so we just want strategies to fix what's wrong with us rather than strategies to help build up a foundation. But I think that metaphor makes a lot of sense. Um, so that's really, really helpful. Thank you.
Definitely, if you ever use this with a client, let them know that they're not going to do it every half an hour, that
Right.
probably 30 or 40% of the time, their watch goes off, their phone goes off, they're going to just reset it. They're going to reset that timer and they don't have time to do it right now.
Mhm.
But on average, people are going to be doing it 6 to 12 times a day. And then they are just getting in the habit of chronically grounding themselves. And over time, we spread it out. It's not 30 minutes for the rest of your life. It's 30 minutes until you feel like, okay, I'm floating a little bit lower. Then let's try every hour. Then let's try every time you go to the bathroom. Then let's try every time you have food. Like what can we kind of tack this to? And eventually it should be parts of their day, not alarm clocks going off. Every time you walk into your office, ground yourself before you do anything. Anchor to that room before you go move on. Something that they're doing 3, 4 times a day. And then it just kind of becomes habitual that every time I do that, every time I enter that space, or every time I brush my teeth, I anchor while I'm doing it.
Yeah. Well, and I would imagine over time, that conscious would move to the unconscious anyway, right? So it's not even, hopefully, it's that we're teaching our body to do those things like breathing
Right.
without even consciously thinking, oh, I need to ground myself. But 6 to 12 times a day is certainly way more than zero. So
Right.
even if they're not doing it every half hour, that's huge progress.
Right.
This has been such a wonderful and helpful conversation. Is there anything that I haven't asked about that you were really hoping you would get to talk about today on this topic?
On this topic, I think there's probably we could talk about it for days. I mean, there's
Sure.
so much we could talk about, but I think this is kind of the starting point for everybody of what can I do to help my clients who are self-harming. And to me, it's more than anything, more than the treatment plan. How do I make my office safe for them to talk about the fact that they're self-harming? How do I help them to know that they're normal, not crazy, that they're not going to the hospital, that I'm not going to dislike them, that these symptoms are okay to have.
Yeah, I
Yeah.
think that's huge. Mhm.
Well, I'd say my self plug, because I think
Yes.
so much out there. There's so many resources, and this can, I think, pair really nicely with self harming. It can pair really nicely with anxiety. And actually, the hot air balloon is part of this program. It's one of the pieces. A colleague and I created Navigating a Stressful World because, oh my goodness, there has been so much stress. We started it when COVID first happened and started putting it together. But it is because, at least in our area, there was no movement in therapy. So people who wanted therapists could not get therapists because no one was leaving their therapist. So there was like no room to bring people in. And so this became kind of this product out of a need of necessity, this online program for those clients who really need to learn cognitive behavioral therapy and how to use it effectively if they cannot see a therapist, or even in conjunction with seeing their therapist, to learn the basics of what are these different techniques? How do I use them? How do I help myself challenge those distortions and recognize those distortions in my functioning? So it's something that I think as clinicians we could use, because I know I've been in and out of therapy for my stresses in life. I am a trauma therapist. I go in and out of therapy for what I have to go through at work. And sometimes therapists remind me of things that I'm like, wow, I know this. I talk about this all day long. Why am I not using this for myself? So I think as therapists, it can be helpful. As a resource for your clients, it can be helpful. And so at anxietyhelp, the number 4u.com, we have this online program. It's all video based, short little chunks of stuff that has worksheets where clients can really learn all of CBT and then use that with you in therapy, or like I said, as a therapist, to be reminded of things that you know, but you just aren't doing.
Yes, that's amazing. Thank you. I was going to ask you to plug yourself, so I'm so glad you did. So it's Anxiety Help, the number 4, the letter U or the word U?
YOU. Yeah.
YOU.com. We'll make sure to put that in the show notes for folks so that they can access that very easily, and click. Is there any other link, or are you on the Instagram or I guess it's called X now, not Twitter? Like, is there any other way that people can investigate and be curious and find out about you and the work that you do? And if they're in your area, work with you?
Absolutely. So I LinkedIn is one place that I have a lot of presence, both as my name and also as navigating a stressful world. Facebook has some navigating the stressful world, but really LinkedIn is probably the easiest way to connect with me as a person. And
Cool.
I love consulting. And so if there's people who just have random questions like, hey, I listened to your podcast, do you have 5 minutes to clarify this? Yes, reach out, definitely ask, and not informal supervision kind of situation, but just as a like clarifying point or to get some resources and to help people. Because I think across the board, we need more clinicians comfortable dealing with this so that it doesn't stay this hidden, dark, secret problem that clients pretend is okay.
Yeah, agreed wholeheartedly. And we'll make sure to put that link in the show notes as well. I'm sure there will be folks that do want to learn more about it, and I hope so. And I really appreciate you sharing your expertise with us and continuing to be available to share your expertise going forward. So thank you so, so much for being with us today, Laura. This was
Oh, thank you
wonderful.
for inviting me, and thank you for hosting this. I think getting good resources out there for clinicians is important, and having resources that aren't just official paid CEUs, but just conversations about these hard topics.
Yeah, that's our goal. Absolutely. Crucial, crucial to collaborate all together. So we're not alone. All right. Well, have a wonderful rest of your day. And we hope we get to talk again soon to you.
Thank you.
Thanks. Bye.